Okay, thank you. Hi, everyone. Thank you, Dr. Francisco Gutierrez. A big thank you for inviting me to give this lecture. My name is Maria Alice. I'm an oncologist from Brazil. I did all my medical training in Porto Alegre at Hospital de Clínicas de Porto Alegre. And I recently moved to Brussels to start a medical research fellow at the Jules Bordet Institute. And my special area of research is breast cancer research. So what we're gonna do, just a second, I have no conflicts of interest to declare to this talk, so it's all my personal opinion, and it's not a statement from the institution I work on. And the plan of the talk is to, Professor Dr. Francisco asked me to choose some abstracts from ASCO, so I chose under the topic of metastatic breast cancer. But do not hesitate of also looking at the abstracts at early breast cancer, which has a lot of very interesting news and data, especially on HER2 positive disease and with the escalation of neoadjuvant therapy, some biomarkers, and also the oncotype study that I think is very important and everyone has to read that. And the talk is going to be divided in two moments. So the first is some abstracts that I thought would be interesting to share. And after, I'm going to talk about the ASCO IDEA 2019 experience and some tips for the future candidates and how to apply to the IDEA 2020. So the first topic that I chose is the Mona Lisa 7 study. So we had a lot of important clinical trials with CDK4 and 6 inhibitors in advanced breast cancer. And we have seen progression-free survival benefit in first line, second and third line, and also in heavily pretreated patients with all the, and we have mainly three representatives of this class. So the palbociclib, ribociclib, and abemaciclib. And it's really a story of success on breast cancer, the CDK4 and 6 inhibitors. And we had seen the benefit on progression-free survival in the early years. And the Mona Lisa 7 study was initially published last year and presented last year. And in case you don't remember the design, so here we can see it's a study for pre- and perimenopausal women with advanced breast cancer, hormonal positive disease that were randomized to ribociclib versus placebo and endocrine therapy. Both arms, they received endocrine therapy with ovarian suppression. So the patients could receive either tamoxifen or an aromatase inhibitors plus ovarian suppression. So the primary endpoint was progression-free survival, and this we saw last year. So we have seen a median PFS of 23.8 months with the ribociclib arm and 13 months in the endocrine therapy arm with a benefit of 10.8 months, okay? And what we saw this year is the overall survival results. So this is very exciting news for us because it's the first time that we have shown an overall survival benefit with a CDK4 and 6 inhibitors in metastatic breast cancer hormonal positive disease. We have to keep in mind that it's very, very hard to show an overall survival benefit in this disease because it is a disease with few events in overall survival, and also because of the crossover and all the treatments. Patients, when they get out of a trial, they end up receiving a lot of treatment lines, and it's hard to show an overall survival benefit. Indeed, most of the decisions that we take in clinical practice, they are based on progression-free survival benefit. And here we see a 29% of relative reduction in death, and this difference is statistically significant. And another way of looking at this is when we look at 36 months, we have approximately 72% of the patients alive in the combination group and 64% in the placebo plus endocrine therapy group. And in 42 months, we have 70% alive in the combination group and 46% in the placebo plus endocrine therapy group. And we also see this benefit in overall survival when we look at the patients that receive aromatase inhibitor, because it could have a difference of receiving tamoxifen or aromatase inhibitors. And we see that it's very homogeneous. So we also found a 30% of relative reduction in the risk of death with the combination. And this difference was also statistically significant. Another worry that we had, and some experts really talk about in some conferences, is that as we could not see the overall survival benefit with these drugs until now, if these drugs would at the end not improve overall survival, and after a patient progressing on CDK4 and 6 inhibitors, the future treatment lines will be shorter because they will become more resistant. And what we see here is that actually no, all the patients, they benefit the same, and the time to the next progression-free survival time, it's better for the combination arm, and also the time to chemotherapy. And this is another study that I would like to put in context to you. It was published now in New England in the beginning of the year, I think in April. And it's about the combination of fulvestrant and anastrozole that also shown a benefit in overall survival, especially for the endocrine therapy naive population, which was 60% of this trial. And also, if we go back here, in the Mona Lisa 7 population, 60% of the patients were endocrine naive. What I mean is that, at least for me, I had some doubts if every patient needed a CDK4 and 6 inhibitor in first line, if we could not wait a little bit, and for some patients use just endocrine therapy, especially the endocrine therapy naive patients. But now this data really changed my mind, and I think if we knock the estrogen receptor very, very strong at first, we might be more effective and have better results. Okay, so this is a way of thinking. And also, who would not benefit of this approach? So we see that patients with primary or second endocrine therapy resistance, they do not really benefit of these. Patients with second endocrine therapy resistance, they benefit, but primary endocrine resistance, they don't benefit at all of this strategy. And this has also been shown last year. So the summary is that the Mona Lisa 7 study is the first trial to show a statistically significant improvement in overall survival with the combination of CDK4/6 inhibitors and endocrine therapy in patients with hormone receptor positive, HER2 negative advanced breast cancer. About toxicities, so this is a very tolerated treatment, and we don't really worry with the toxicities. They exist, but they are easily manageable. So what we observe in this trial, which is important to highlight, is that for the patients who receive tamoxifen and a CDK4 and 6 inhibitors, we could see a larger interval KT in the electrocardiogram. So this is something that we worried, and if we want to choose a preferable regimen, we would choose aromatase inhibitor with ovarian suppression and a CDK4 and 6 inhibitors because of this cardiac particularity. Okay, and although we have this class of drugs which are very tolerable and they don't reduce quality of life, they are effective for the very prevalent disease, and now we have a benefit in overall survival, I think we need to also discuss the access to these drugs, especially in Latin America. At least in Brazil, when I was in residency, we did not have access to these drugs for the public health system. And I think some new cost effectiveness studies in our countries could be very interesting to see the benefit of these drugs in our population. And how could we offer this to our patients? So another study, also in premenopausal women, It's a Korean study that I found very interesting because it enlightens me it highlights some doubts that I had, and I would like to discuss with you. It's a prospective phase 2 trial that randomized premenopausal women with metastatic breast cancer, hormonal positive, to palbociclib plus exemestane and ovarian suppression against chemotherapy. So the primary endpoint of this study was progression-free survival. And we have to keep in mind it's a phase 2 study, and the population is kind of heterogeneous here. We have 50% of the patients with visceral disease, 50% of patients with treatment-naive disease for advanced disease, so that never receive chemotherapy or another treatment line for metastatic disease, and 56% with only one metastatic site. But we can see, and it's, no one ever had shown this, that we know that endocrine therapy is better than chemotherapy for metastatic hormonal positive breast cancer. But sometimes in premenopausal women, especially young women, and we know that in Brazil we have a higher number of these cases, and also in other Latin American countries as well. Some oncologists get scared, and because it seems that these patients have a worse disease and a more aggressive disease, it gets them a bigger tend to prescribe chemotherapy. And what we see here is a big advantage of the CDK4/6 inhibitor plus endocrine therapy against chemotherapy in this population. Of course, we need to confirm this data with another ongoing clinical trials, especially phase 3 trials. And there are some open questions if capecitabine is the right control arm for this study. And the one that I think is the most interesting data, and I really hope that someone answers that and show us some results, are these data applicable in a high burden disease? So patients with visceral crisis, we usually prescribe chemotherapy, but given that this class of drugs has a very nice response rate and a tolerability very, very nice also. We don't actually know if they would not work even better than chemotherapy for this population. So this is still an open question. And going still on the abstracts about CDK4 and 6 inhibitors, some very nice presentations were trying to identify who would benefit more from CDK4/6 inhibitors and who would not benefit from a CDK4 and 6 inhibitor. And so there was a sub-analysis of the Mona Lisa 7 study that showed that patients had a higher magnitude of benefit of a CDK4 and 6 inhibitor when they presented a high cyclin D1 level, high EGFR1, HER3, low cyclin E, and MIC levels. Another abstract presented about a sub-analysis of the Paloma 3 trial, looking at ctDNA, found a lower magnitude of benefit in patients with cyclin E gain, FGFR gain, p53 mutations, and a high ctDNA fraction. And the one that I thought was the most interesting one was an abstract presented by the doctors from the Memorial Sloan Kettering, and they tried to identify patients that would not respond at all from a CDK4/6 inhibitor. So looking at primary resistance, and what they found is that RB1 loss and FET1 loss alterations could be related to intrinsic resistance on CDK4/6 inhibitors. This paper is published and it's very nice. And of course, in Latin America, we don't have access to next generation sequencing to identify and select the patients, but this is something that we have to keep in mind that exists. So now, changing subjects, I would also like to highlight the advances in HER2-positive metastatic breast cancer. So the Cleopatra end of study results. So the Cleopatra regimen, all of you, I believe, know, it was presented in 2015. and it showed a 15.7 months increase in overall survival with the dual HER2 blockade, trastuzumab, pertuzumab, and docetaxel versus trastuzumab and docetaxel. And with a median follow-up of 50 months, the overall survival was 56.5 months versus 40 months in the previous publication. And now they presented the end of study results after 8 years, and they pretty much don't change. So I think we need to be very proud of these advances in HER2 positive disease. Of course, we have a lot of challenges to discuss and to approach, especially brain metastasis in HER2 positive disease, after progression of TDM1 disease, intrinsic resistance to HER2 target agents. But this is a very nice job that we as oncologists have done here. So the PFS after 8 years is still 18.7 months. And the overall survival benefit, if you look at 8 years, we have a landmark of 37% alive in the dual HER2 blockade group against 23% alive in the trastuzumab group. This is very, very, very nice. And it also gives us more data on toxicity. We have a little bit of diarrhea, especially in the beginning, in the first cycles. And we have more safety data on cardiac results. So it really seems that it's not, we don't have a higher cardiotoxicity with dual HER2 blockade. And we can be safe on prescribing these drugs. So the first and last abstract that I'm gonna discuss with you is not on metastatic breast cancer, but especially a topic that I like a lot. It's survivorship. And there is this very interesting study on pregnancy in BRCA mutated patients that I would like to highlight. So this is an Italian study, is a multi-center study. And what they do was presented by Matteo Lambertini. And what they do is that they look at more than 1,000 patients with BRCA mutation, and they look for pregnancies, okay? And they found 195 pregnancies. It's 16% of the cohort had a pregnancy after a breast cancer diagnosis in BRCA mutated patients. And they did a case control approach and paired the patients with the same baseline characteristics to see the outcomes after a pregnancy or not, okay? And we have in the end 176 patients, pregnant patients, and 528 matched controls. And at the end of 8.3 years, we see that the disease-free survival is not worse, and it's not different, and even better for the pregnancy cohort than the non-pregnancy cohort. And when we look at the type of BRCA mutation, we also see there's no difference between BRCA1 and BRCA2, and this advantage of having a pregnancy, it's more special for the hormonal receptor negative subtype. And this has also been shown, I don't remember exactly the year, but it was published in Annals of Oncology by Azim, also shown that a pregnancy could be protective for triple negative breast cancer. We just need to exactly know the best timing for this, okay? And they looked at overall survival also, and they didn't find a difference between the patients that had a pregnancy and didn't have a pregnancy. So the conclusions of this study is a large cohort of BRCA mutated patients, and they found 16% of pregnancy following breast cancer, and they found no detrimental effect of pregnancy on disease-free survival and overall survival. And the fetal and pregnancy complications appear similar in those patients as the general population. And this study is very important because it reassures the counseling of young BRCA mutated breast cancer patients. This is also important because they have the oophorectomy intervention. So if they really want to have a pregnancy and they are young, it's not, you cannot say that it's impossible for them to have a pregnancy, and it does not interfere in the breast cancer outcome. So it's a difficult issue, and I brought this study here because I'm glad there are people studying this, because fertility issues are a priority for young women with breast cancer, and we really need to discuss this. And now I'm going to change my topic, and this talk right now is really addressed for young oncologists from Latin America. And my message is really my opinion, but it has something that someone very special told me, and I really agree, is that the importance of the research in the oncologist's life. I believe, for me, it's very important for the oncologist to also be related to some kind of research. It doesn't have to be translational, it doesn't have to be laboratorial or epidemiology. It has to be something that you like to do, because when we see patients from 8 a.m. to 8 p.m. every day, the chances of having a burnout and stress, and because there are so many difficult cases, and our life decisions implicate the life of a lot of patients. And I think when you're involved in research, you get less burnout, because you see that there are good things coming, and you get more optimistic, and you transmit this to your patients, and you transmit this to your clinical practice. So I think it's very, very, very nice thing to do. You just have to find a topic that you like the most. And the other tip is that I believe no one is going to come and tell you everything that you should do and how to apply to a research opportunity or a research grant. But if you ask, people usually answer you. And so this is not really an academic race or getting titles, but it's doing something that you like, and it will also help others, and being proactive. So the first tip that I have is that you should be part of the oncology societies in your country and also outside your country. So I can say at Brazil, the Brazilian Society of Oncology, clinical oncology, has a lot of programs for young oncologists, and with opportunities to go to ASCO and to be involved in some research. And from ESMO and ESO also, which are the European Society of Oncology, we have the Latin America Masterclass of Clinical Oncology that happens every year. And it is a very nice opportunity. You get to know all the big professors from ESMO, and they are available to discuss with you, and and you see that they have the same doubts as you in the clinical practice. And this is amazing. When you see the big guys discussing the case that you take to the masterclass, it's very nice. To apply, you just have to go to the website and look at it. It's the ESO, European School of Oncology, and it's a very nice thing. They also have a clinical training centers fellowships, which have programs for 3 months and 6 months. You can apply. They have the translational research unit visits, which is a five days immersion on a translational research lab. And they have the international fellowship of 1 year, the palliative care fellowship, and the clinical unit visits. So there are a lot of people that cannot go away from their country for 1 year or longer. But these short time experiences, I think they are very nice, and they give you insights and connections important to realize what you can do better. Because the point is not just traveling outside from your country, but it's learning better things and improving and bringing back to your country and making things better. For the ASCO, and I highlighted in red the ones that I participated, and I'm very proud of that because I'm sure they helped me a lot. So from ASCO, we have the Virtual Mentors program, which is a very nice program. They pair you with an American or Canadian senior oncologist for 1 year, and you get to connect virtually with this mentor for 1 year. So if you cannot leave your country, this is a great opportunity for you to be connected with international research. So I did this for 1 year, and I was paired with Professor Ortobagi from MD Anderson. It was an amazing opportunity for me because he was really a mentor for me. We could publish an article together, and I could learn a lot with him. It's not about your accomplishments, but it's about what you do and how you improve yourself during the way. And we also have the International Development Award, which is the IDEA Award that I'm going to tell you about. The Long International Fellowship Award, which is a 1-year research opportunity in an American institution. The Global Oncology Young Investigator Award, the Young Investigator Award, the Career Development Award, the ASCO Journal's Editorial Fellowship Program, and the Journal of Oncology Prize Editorial Fellowship Program, which is a sub-program of the ASCO Journal Editorial Fellowship. And I would like to highlight that in 2019, this year, more than $7 million were donated from the Conquer Cancer Foundation to support cancer research. And this was internationally. This is a picture from the ceremony, the IDEA ceremony. And here you can see that you are not alone. If you're trying to do some research or applying to a grant, you need to know that all these people in the picture, they really apply a lot of times, and it's a matter of applying, failing, and applying again. So the ASCO IDEA 2019, it's not just 2019, but the International Development Award Program is the first step into the ASCO Awards. Why is it nice and important? Because it is designed for young oncologists in developing countries, and you get to connect with young oncologists from all over the world that are facing the same challenges of you or even bigger than you, and you see how big the research community is, and you get the full ASCO package. And when I say full ASCO package, I really mean, because they give you hotel, airplane tickets, visa costs, insurance, and a little bit of money for your personal expenses. So you really have this whole group working for you, and to make this experience the best you can have. You have full access to the meeting slides. You have 3 years of ASCO membership. You have access to ticketed sessions, presidential dinner, World Oncology Leaders Reunion, and grant ceremony. And these meetings, they are very selected, and you get the opportunity of talking of big researchers in oncology that did great things, and they are so interested on you in your country and how oncology is in your country. And these are important moments that you can connect with people and build a network that can help you in your country as well. And we also had the Train the Trainer course, where they gave us tips for exposing our ideas and how to talk in public and give interviews. And it was very nice and fun and also intense, okay? So besides the full ASCO package, you also are awarded with an extended award tour, which is you are paired with a mentor, okay? And after the meeting, you go to your mentor institution and you spend 4 days there. And you should previously discuss by email with your mentor what you want to do and what you want to see in this visit, okay? And I had the opportunity to go to the MD Anderson Cancer Center, which is one of the biggest cancer institutions in the United States. And I stayed there with Professor Ortobagi at the breast cancer unit. It was 4 intense days, so our activities started at 7:30 a.m. and ended up 19 p.m. And I had the opportunity to watch consultations with him, to go to the phase 1 unit and see the huge phase 1 unit that they have in the Anderson, see patients and see the protocols. Also go to the translational research unit. I got to know the genetic program and all the consiliums, the radiotherapy unit, the inflammatory breast cancer clinic, the triple negative unit, the first consultation model, which they have a multidisciplinary approach that the patient, when it comes for a first visit, they the patients are seen by all the specialties. So they are seen by the genetics, the medical oncologist, the radiotherapist, the surgeon, the psychologist. They rotate in all the specialties. It's very interesting. I also got to know the survivorship program. I get to go to some tumor boards and to the post-ASCO internal breast unit discussion. How can you apply and who can apply to this idea, to this award? So you have the International Development Award and the International Development Award Palliative Care. So if you're interested on palliative care, you can also apply to this award. So when applying, you have to be a resident of a country classified by the World Bank as low or middle income country, and have limited resources to attend ASCO annual meeting. You cannot have completed more than one academic year of formal training outside your country or in a high income country. But you can, if you spend some time outside and you want to go apply to the idea, you can do it. We had one of my colleagues had spent 8 months in the United States and was now an idea award. Okay. So you have to be member of ASCO. So this we already talked. You have to be part of the medical societies. You gotta have less than 10 years of the pass from your training program and be fluent in English, okay? And criteria to qualify, who is selected to the IDEA Award, is really not just about your CV. So you don't have to be afraid of applying. It's more about what you want to do with this opportunity. What is your goal? How bad do you want to do it? And this comes from, at least myself, I had applied twice to the IDEA Award. And the first time I didn't even get close, but it was okay because I tried it again. And another very important topic is how can you help your community in the future with this experience, and what you want to do with the knowledge you get, okay? And the first step is really to apply. And if I could advise something, I would advise you to apply in the first year of residency. Because if you get the opportunity of going in the second year, you can build a very important connection and network for future research and opportunities. This was what I wanted to talk to you. I thank you very much for the opportunity. I'm very available to help. If anyone has any doubts, they can send me an email or contact me, and that's it.
Maria, thank you so much for your excellent talk.
Thank you.
Very interesting. Is there any question from the audience? In YouTube, we have more participants.
Okay.
But they can send questions by mail.
Yeah, of course. They can send me an email and I will be very delighted to answer them.